welcome back to the deep dive. If you wear complete dentures, or if you're in prosthodontics, you definitely know this world is way more complex than just, false teeth.
Oh, absolutely.
We're not talking about a simple loose fit here. It's a huge diagnostic puzzle, really.
It is.
Our sources today are pointing out there are, over 40 different things that can go wrong after insertion?
Yeah.
From tiny irritations to, major fit problems.
That's right. And that's the core challenge, isn't it? When a patient says, this just doesn't feel right, you as the clinician have to figure out why.
Right. Is it just getting used to them?
Exactly. Is it adjustment?
Great.
Or is it the denture settling naturally? Or, was there actually an error in how they were made that's only showing up now?
Yeah.
Getting that diagnosis spot on, well, that's what we're diving into today.
Perfect. So let's start with the most common thing. Pain, irritation. Seem like we need to separate issues that affect the whole area versus very specific spots.
That's the first split, yes. Generalized versus localized.
So if it's generalized, like the whole mouth feels off or burns, where do you look first?
The first suspect usually is an issue with the vertical dimension of occlusion, the VDO.
VDO.
Yeah.
Unpack that a bit.
Simply put, it's how far apart the jaws are when the teeth are together. If that distance is too big, the bite's too high, the muscles are just constantly working overtime, strained.
Leading to that generalized discomfort.
Exactly. It's just tiring and uncomfortable everywhere.
And isn't there a classic kind of telltale sign patients mention when the VDO is too high? Something about speaking.
Yes. The classic complaint is, my teeth click when I talk. It's like they can't quite close comfortably, and you hear that little click as the teeth make first contact during speech.
Ah, that's so specific. So you hear the click, you think VDO?
It's a very strong clue. Now, if it's just a slight increase, maybe you can grind the teeth down a bit.
Okay.
But if it's excessive, grinding won't cut it. You're looking at redoing the denture, a remake.
Makes sense. You can't just grind away that much tooth structure.
Not without compromising function, no. Another big generalized issue is a mismatch, a disharmony between where the teeth naturally meet, centric occlusion, and the jaw's most stable position, centric relation.
Okay, how does that show up?
You actually see it. The lower denture, the mandibular one, visibly slides forward when the patient closes, just shifts anteriorly.
Why does it do that? What's pushing it?
Well, think of it like a tiny ramp. There's a high spot, a premature contact somewhere. As they bite, that high spot forces the lower jaw forward, sliding the whole denture until everything finally settles.
Ah, I see. So that needs adjustment too, like grinding.
Yep. Occlusal equilibration. You have to smooth out that ramp, basically harmonize the contact so it closes smoothly without shifting.
Got it. And then there's the allergy issue. You mentioned it's rare, but it sounds pretty miserable with that bright red burning feeling.
It is miserable. And yes, classic signs, burning, really red mucosa. Usually, if it is an allergy, it might be to the residual monomer.
Monomer, the leftover chemical from the acrylic.
Exactly. If the PMMA acrylic didn't fully cure, those leftover bits can leach out and irritate the heck out of the tissues.
So the fix isn't just like an allergy pill.
No, you need to address the source. That usually means relining the denture with a properly heat-cured acrylic, which minimizes that free monomer. Or maybe rebasing it. You have to seal it off or ensure it's fully polymerized.
Okay, isolating the irritant. That makes sense.
Right.
So if we've ruled out those big generalized problems, now we zoom in. Localized pain. The detective work begins. How do you pinpoint that one tiny spot causing an ulcer?
For that, we have a fantastic, simple tool. Pressure indicator paste, PIP.
PIP. How does that work?
You paint a really thin, even layer inside the denture on the fitting surface. Then the patient puts it in and bites gently.
Okay.
Wherever there's too much pressure, maybe a flange is too long, or there's a sharp little bump, the paste gets scraped away. It leaves a little clear spot where you can see the pink denture base underneath.
Like a little window to the problem area.
Exactly. That window tells you precisely where you need to adjust, where to grind just a tiny bit for relief.
That's brilliant. So using PIP, what kind of specific sore spots often show up?
Well, you might find irritation right on the crest of the ridge. That could be one of those deflective contacts we talked about.
A ramp thing again?
Could be. Or sometimes it's literally a tiny sharp bit of bone underneath the tissue, a bone spicule. That might need a tiny surgical fix.
Okay.
Another really common painful spot is along the midline of the median palatine rough, that hard ridge down the center.
Ah, yes. And the clue for that one? Didn't the source say the denture rocks?
That's the dead giveaway. If not enough relief was put in the denture over that hard, non-squishy midline during fabrication, the denture teeters on it, like a seesaw.
Right.
You press on one side, the other side lifts up, so you have to carefully relieve the denture right along that midline.
Makes sense. And maybe the worst, localized pain pressure on the mental nerve.
Yeah.
That sounds awful.
Oh, it is. It really is. You see this mostly in lower jaws, where the bone has resorbed quite a lot.
So the bone has worn down.
Yeah, worn down so much that the little hole where the mental nerve comes out, the mental foramen, is now practically right on the surface where the denture sits.
Ouch.
The pain is sharp, often in the lower premolar area, sometimes radiating to the lip or chin. It's intense.
So the fix there is immediate relief of the denture base right over that nerve.
Absolutely. You confirm it first, gently press with your finger over where the foramen should be. If the patient practically jumps, you know exactly where to grind. No hesitation.
Wow. Okay, let's switch gears from direct pain to other things that really affect quality of life. Nausea and altered taste. Nausea seems like it could be psychological, but you're saying it often has a physical cause.
Yes, while anxiety can worsen it, nausea frequently has a mechanical trigger, especially with the upper denture.
How so?
It's often the back edge, the posterior border, if it's too thick, or if it makes just a light intermittent contact with the soft palate that can trigger the gag reflex. Ah, the gag reflex.
Right, or even just the thickness irritating the back of the tongue. The tongue's always moving, trying to adapt, and this thick thing is back there. It can definitely cause nausea.
Okay. And taste. Can the denture material itself actually mess with how food tastes?
It absolutely can, and it comes down to, well, physics mostly. The acrylic base is a poor conductor of heat.
An insulator.
Exactly. And we sense a lot of the taste or enjoyment of food through temperature, especially on the palate. Hot coffee, cold ice cream.
Right.
The thick acrylic insulates the palate, blocking that thermal feedback, so food just tastes bland, less vibrant. The temperature cues are missing.
That's fascinating. It's the insulation blocking the temperature sense.
That's a huge part of it. Plus, sometimes the acrylic itself can be slightly porous, microscopic holes.
And things get trapped in there.
Yep. Food debris, bacteria. That can lead to bad tastes or odors, too. For really persistent cases, sometimes switching to a metal-based denture helps. Metal is thin, conducts temperature beautifully. Interesting solution. Okay, so that covers a lot of the immediate post-insertion complaints. But what if the problem is deeper, like the actual foundation, the bone and tissue? Let's talk about tricky anatomy, specifically flabby ridges and also the geriatric patient.
Okay, yeah. Flabby ridges, or technically fibrous displaceable tissues, are a major headache. You see them most often in the upper front area, the maxillary anterior region.
And it's often linked to something called the combination syndrome, right? Sounds ominous.
It kind of is, structurally. It happens when you have a full upper denture opposing only natural lower front teeth, no back teeth on the bottom.
Ah, so all the chewing force goes to the front.
Precisely. All the bite force gets concentrated on those few lower natural teeth hitting the front part of the upper denture. That repeated hammering causes the upper front bone to resorb much faster than usual.
And the bone disappears, leaving just soft tissue.
Leaving just that soft, mobile, fibrous tissue, the flabby ridge. It's got no bony support underneath.
So obviously taking a standard impression of that would just squish out of place.
Totally. You'd get a distorted impression and a denture that won't fit. So before you even think about a new impression, you need a tissue recovery plan.
Okay, what does that involve?
Reducing inflammation is key. The patient needs to leave the denture out for significant periods, like at least 8 hours a day, usually overnight. Plus, massage the tissues, maybe saltwater rinses. Let things calm down and firm up a bit.
And then mechanically, you need to get the pressure off that front area while things heal and before the new denture.
Yes. That's where occlusal pivots come in. It's a temporary fix on the old denture.
Pivots.
You add little blobs of self-curing acrylic onto the back teeth surfaces only. This raises the bite slightly in the back, creating contact only on those pivots.
So it lifts the front segment off the ridge.
Exactly. It restores some posterior support, takes the load off that damaged front area, and lets the tissue recover properly before you attempt a special impression technique.
What kind of technique?
Usually a sectional or two-stage impression. Something designed to capture that flabby tissue gently without distorting it.
Very careful work. Now, shifting to the geriatric patient, they bring a whole different set of challenges, right? Beyond just the anatomy. The sources mention things like extreme bone loss leading to prognathism of age.
Yes, that prognathism is the visual change. The lower jaw looks more prominent because the bone, especially the maxilla, has shrunk and the jaw angle changes. But clinically, the really big deal is that extreme bone resorption.
How does that affect things?
Well, the mucosa, the gum tissue, gets thinner, more fragile, easily irritated. And like we touched on with the mental nerve, the bone loss can be so severe that nerve exits or even the mandibular canal itself in the lower jaw can end up basically exposed right on the ridge surface.
Which makes wearing a denture incredibly difficult, potentially painful.
Extremely difficult. And this leads to a really crucial point in managing older patients, something the sources emphasize strongly. Be very careful about forcing new dentures on someone who's actually happy with their old ones.
Even if the old ones look worn out or the fit seems objectively bad?
Even then. If an elderly patient has been wearing the same dentures for years, maybe decades, and they're functioning okay, eating reasonably well, and not in pain, their brain and muscles have adapted. They've established neuromuscular control over those specific shapes.
The brain learns to handle the imperfections.
Precisely. Trying to impose a technically better new denture with a different shape and bite can completely disrupt that adaptation. The risk of the patient rejecting the new ones is very high. We only push for new dentures if the old ones are actively causing tissue damage, like ulcers or severe inflammation.
That respect for neuromuscular control also connects to copy dentures, doesn't it? Explain those quickly.
Right. Copy dentures are essentially duplicates of the patient's existing successful dentures. You preserve the shape, the tooth position, the polished surfaces that the tongue and cheeks are used to. It leverages their existing adaptation.
It's respecting the learning curve they've already climbed.
Exactly. Especially important for the elderly.
And another age-related change. The space between the jaws when resting, the interocclusal distance, gets bigger.
Yes, it tends to increase with age. Instead of the typical 2 to 4 millimeters, you might see 5, even up to 10 millimeters of rest space being appropriate.
So if you do need to make a big change, say, restore a collapsed bite.
Go slowly. You absolutely cannot make drastic changes all at once. The rule of thumb is maybe no more than 5 millimeters of vertical dimension increase at a time. Let them adapt, then maybe adjust more later if needed. Patience is key. Short visits, realistic goals.
That measured patient approach seems like a good bridge to our last section.
Oh.
High-tech helpers for these tricky situations. Let's talk retention over dentures first. We know they save bone, but you mentioned proprioception as another huge benefit.
Yes. For me, that's almost the biggest benefit besides bone preservation. Proprioception is that sense of where your body parts are, how hard you're pushing or biting.
Okay.
When you keep even a few natural tooth roots for an overdenture, you keep the periodontal ligament around them. That ligament is packed with nerves that send feedback to the brain.
So the patient can actually feel the bite better.
Infinitely better. They get a sense of pressure, of position, that's just completely lost with a conventional denture sitting only on the gums. It feels much less like a foreign object.
Makes the denture feel more like part of them. How are they held in place?
Various ways. We use attachments. Common types are stud attachments, like little snaps on the roots, bar attachments where a metal bar connects roots and the denture clips onto it. These can be rigid or allow some movement, and even magnetic retention.
Magnets. Really?
Yep, tiny magnets in the root cap and the denture. Simple passive retention. Easy for patients with dexterity issues, perhaps.
Cool. And if there are no roots left at all, then it's implants. The all-on-4 concept gets mentioned a lot for full eyes. What's the clever bit there?
All-on-4 is a technique to get a full fixed bridge, often loaded immediately, on just 4 implants. The clever part is the placement of the back implants.
How so?
The front 2 go in straight, vertically, but the back 2 are tilted, angled sometimes up to 45 degrees.
Why angle them?
Angling lets you use longer implants, which means better stability and potentially less bone. Crucially, it also helps you avoid important structures in the back, like the nerve in the lower jaw or the sinus in the upper jaw, without needing complex bone grafting.
Smart geometry. Okay, now for the really cutting-edge stuff. Digital dentures using CAD/CAM. The big sell seems to be speed, right? Fewer appointments?
Oh, the time saving is enormous. Think about the traditional process, 5, 6, sometimes more appointments, impressions, bite rims, try-ins.
That's a lot.
With digital, you can potentially do it in just 2 main clinical visits. One for scanning and records, the next for inserting the finished denture.
That's a massive difference, especially for older or medically compromised patients.
Huge. And beyond speed, there are quality benefits too. The denture base is usually milled from a solid block of pre-polymerized acrylic.
Meaning less warping.
Exactly. You minimize the polymerization shrinkage that happens when traditional dentures are processed. That means potentially a better fit, better adaptation, and the material is often less porous, too.
Less porous. So maybe fewer taste issues like we discussed.
Potentially, yes. Less chance for bacteria to hide. And the other big plus, the digital file.
The digital depository.
Right. If the patient loses or breaks their denture, you just pull up the file and mill or print a new one instantly. No need to start all over with impressions. It's a fantastic backup.
Okay. Sounds almost too good to be true.
Yeah.
What's the catch? I remember reading that scanning inside the mouth for a fully toothless jaw is actually really hard.
It is. That's still the big hurdle. Intraoral scanning works great for teeth. Lots of distinct shapes and landmarks. But an edentulous ridge, it's smooth, often wet and shiny with saliva, and the tissues can move.
So the scanner gets lost.
It struggles to stitch the images together accurately because there aren't enough unique points to lock onto, so clinicians have to get creative, using some surprisingly low-tech tricks like drawing little lines on the palate with a special paste or placing tiny dots of flowable composite material at specific spots just to give the scanner something clear and stable to track.
High-tech scanners needing Sharpie lines, basically.
Kind of. It highlights that blend of advanced tech and practical problem solving.
It really does. We've gone from worrying about microscopic bits of leftover monomer causing irritation,
Right.
all the way through major structural issues like combination syndrome, needing careful tissue management,
And occlusal pivots.
and ended up with implants avoiding nerves, and digital milling needing reference dots. It covers such a range.
It really does. And I think the takeaway is that every single one of those patient complaints, whether it's clicking teeth, a rocking palate, nausea, a flabby ridge, it has a specific cause and a logical diagnostic pathway.
It's not just guesswork.
Not at all.
Yeah.
It's about knowing what to look for, how to test for it. That specialized knowledge is what leads to a successful outcome.
So earlier we talked about the happy older patient with worn-out dentures.
Oh.
The idea behind the copy denture, respecting that learned neuromuscular control.
Yes, preserving that adaptation.
And now we've just discussed the incredible precision of digital dentures, superior fit, minimal shrinkage, theoretically perfect.
The cutting edge of accuracy.
Which leaves us with a really fascinating final thought, doesn't it? It's this tension. Is the technically superior accuracy, the perfect fit from a brand new CAD/CAM denture, always the best choice? Or is there sometimes more value in preserving the slightly imperfect, but deeply learned and adapted shape of an old denture that the patient has spent years mastering?
That's the million-dollar question, isn't it? Perfect engineering versus ingrained human adaptation. It's a balance prosthodontists navigate every single day. Where does pure technical perfection meet individual biological reality? Something to definitely think about.